Hi, I'm Dr. Boris Sepeshi. I'm a thoracic surgeon at Sarah Cannon Cancer Network, HCA Health 1 in Englewood, Colorado. With the recent approvals of treatment options for resectable non-small cell lung cancer, we, as surgeons, need to look for ways to extend our roles in the early stage setting. Any surgeon who operates on these patients, whether they are thoracic surgeons or not, should know that resectable non-small cell lung cancer is heterogeneous and often involves micrometastatic disease. Cancer cells that spread beyond the tumor may lead to recurrence after surgery. Patients with resectable non-small cell lung cancer may require a multimodal approach that includes surgery and systemic treatment. A key way we can extend our roles in early-stage non-small cell lung cancer is by collaborating with medical oncologists and the other specialists on the multidisciplinary team to ensure appropriate patients receive treatment with a perioperative IO regimen, such as the AEGEAN regimen with IMFINZI. In my opinion, experience matters in treating lung cancer. IMFINZI is the only FDA-approved immunotherapy following chemoradiation in unresectable stage 3 non-small cell lung cancer and as perioperative treatment in resectable stage 2 to 3 non-small cell lung cancer in these two curative intent settings. IMFINZI has over 7 years in clinical practice and over 100,000 patients treated for resectable and unresectable stage 3 non-small cell lung cancer. As we know, AEGEAN was a perioperative immunotherapy trial in stage 2A to 3B and 2 resectable non-small cell lung cancer with neoadjuvant IMFINZI plus choice of platinum-based chemotherapy followed by adjuvant IMFINZI. The protocol was amended while enrollment was ongoing to exclude patients with documented EGFR or ALK alterations, T4 invasion, satellite tumors, and planned pneumonectomies. The co-primary efficacy endpoints were EFS and PCR. All efficacy analyses were performed on the modified intent-to-treat population. The trial showed improvements with perioperative IMFINZI-based treatment versus neoadjuvant chemotherapy alone in EFS and PCR. In a first interim analysis, median EFS was not reached in patients treated with the AEGEAN regimen and was 25.9 months in patients treated with neoadjuvant chemotherapy alone with hazard ratio of 0.68. There was a demonstrated safety profile with perioperative IMFINZI-based treatment. The most common adverse reactions occurring in 20% or more of patients were anemia, nausea, constipation, fatigue, musculoskeletal pain, and rash. The incidence of treatment-related maximum grade 3 or 4 adverse reactions was 32.4% in patients receiving the AEGEAN regimen and 32.9% in patients receiving neoadjuvant chemotherapy alone. Here's additional safety information. Select laboratory abnormalities with 20% or more worsening from baseline in the AEGEAN study included blood and chemistry changes as shown on the screen. Here's additional safety information from the neoadjuvant phase of AEGEAN. Of the 401 IMFINZI-treated patients and 398 placebo-treated patients who received neoadjuvant treatment, 1.7%, N equals 7, and 1%, N equals 4, respectively, did not receive surgery due to adverse reactions. Of the 325 IMFINZI-treated patients who received surgery, 4%, N equals 15, experienced delay of surgery due to adverse reactions. Of the 326 placebo-treated patients who received surgery, 4%, N equals 16, experienced delay of surgery due to adverse reactions. Let's discuss surgical outcomes in the AEGEAN study. It is important to note that treatment completion data and surgical outcome data were not tested for statistical significance. 81% of patients in both arms underwent surgery. R0 resection was achieved by 95% of patients receiving the AEGEAN regimen who completed surgery and 91% of patients receiving neoadjuvant chemotherapy alone. Within the AEGEAN modified intent-to-treat population, surgical delays occurred in 17% of patients receiving the AEGEAN regimen and 22% of patients receiving neoadjuvant chemotherapy alone. Since the approval of the AEGEAN regimen last year, I've had a number of patients started on IMFINZI plus chemotherapy before surgery, so I have some experience with the regimen. In my opinion, the flexibility to choose between platinum-based chemotherapy regimens can be helpful. Some patients have tolerability issues with cisplatin that might be avoided by using carboplatin instead. Here are 3 images of a patient on the AEGEAN regimen. At diagnosis, post-treatment, and post-surgery. My surgical experience aligns with results from the trial. In my practice, I haven't noticed any significant surgical delays or experienced complications that I felt made my surgeries more difficult, although I'm prepared for any complications that might occur. Some surgeries might have been longer, but not significantly so. Additionally, my R0 resection rate has been close to the 95% in the trial. My experience with IMFINZI began in 2018 with the approval for unresectable stage 3 non-small cell lung cancer, when we had a great deal of discussion in tumor board about which patients were truly unresectable. In my opinion, it's important to refer appropriate patients with resectable non-small cell lung cancer to medical oncologists for consideration of perioperative IO treatment. Be sure to like the video and subscribe to this channel for more expert insights. Please stay tuned for the important safety information for IMFINZI.
Important safety information. There are no contraindications for IMFINZI, durvalumab. Immune-mediated adverse reactions. Important immune-mediated adverse reactions listed under warnings and precautions may not include all possible severe and fatal immune-mediated reactions. Immune-mediated adverse reactions, which may be severe or fatal, can occur in any organ system or tissue. Immune-mediated adverse reactions can occur at any time after starting treatment or after discontinuation. Monitor patients closely for symptoms and signs that may be clinical manifestations of underlying immune-mediated adverse reactions. Evaluate liver enzymes, creatinine, and thyroid function at baseline and periodically during treatment. In cases of suspected immune-mediated adverse reactions, initiate appropriate workup to exclude alternative etiologies, including infection. Institute medical management promptly, including specialty consultation as appropriate. Withhold or permanently discontinue IMFINZI depending on severity. See USPI dosing and administration for specific details. In general, if IMFINZI requires interruption or discontinuation, administer systemic corticosteroid therapy, 1 mg to 2 mg per kilogram per day, prednisone or equivalent, until improvement to grade 1 or less. Upon improvement to grade 1 or less, initiate corticosteroid taper and continue to taper over at least 1 month. Consider administration of other systemic immunosuppressants in patients whose immune-mediated adverse reactions are not controlled with corticosteroid therapy. Immune-mediated pneumonitis. IMFINZI can cause immune-mediated pneumonitis. The incidence of pneumonitis is higher in patients who have received prior thoracic radiation. In patients who did not receive recent prior radiation, the incidence of immune-mediated pneumonitis was 2.4%, 34 of 1,414, including fatal, less than 0.1%, and grade 3 to 4, 0.4%, adverse reactions. In patients who received recent prior radiation, the incidence of pneumonitis, including radiation pneumonitis, in patients with unresectable stage 3 NSCLC following definitive chemoradiation within 42 days prior to initiation of IMFINZI in Pacific was 18.3%, 87 of 475, in patients receiving IMFINZI, and 12.8%, 30 of 234, in patients receiving placebo. Of the patients who received IMFINZI, 475, 1.1% were fatal, and 2.7% were grade 3 adverse reactions. The frequency and severity of immune-mediated pneumonitis in patients who did not receive definitive chemoradiation prior to IMFINZI were similar in patients who received IMFINZI as a single agent or with ES-SCLC or BTC when given in combination with chemotherapy. Immune-mediated colitis. IMFINZI can cause immune-mediated colitis that is frequently associated with diarrhea. Cytomegalovirus, CMV, infection reactivation has been reported in patients with corticosteroid refractory Immune-mediated colitis. In cases of corticosteroid refractory colitis, consider repeating infectious workup to exclude alternative etiologies. Immune-mediated colitis occurred in 2%, 37 of 1,889, of patients receiving IMFINZI, including grade 4, less than 0.1%, and grade 3, 0.4%, adverse reactions. Immune-mediated hepatitis. IMFINZI can cause immune-mediated hepatitis. Immune-mediated hepatitis occurred in 2.8%, 52 of 1,889, of patients receiving IMFINZI, including fatal, 0.2%, grade 4, 0.3%, and grade 3, 1.4%, adverse reactions. Immune-mediated endocrinopathies. Adrenal insufficiency. IMFINZI can cause primary or secondary adrenal insufficiency. For grade 2 or higher adrenal insufficiency, initiate symptomatic treatment, including hormone replacement, as clinically indicated. Immune-mediated adrenal insufficiency occurred in 0.5%, 9 of 1,889, of patients receiving IMFINZI, including grade 3, less than 0.1%, adverse reactions. Hypophysitis. IMFINZI can cause immune-mediated hypophysitis. Hypophysitis can present with acute symptoms associated with mass effect, such as headache, photophobia, or visual field cuts. Hypophysitis can cause hypopituitarism. Initiate symptomatic treatment, including hormone replacement, as clinically indicated. Grade 3 hypophysitis-hypopituitarism occurred in less than 0.1%, 1 of 1,889 of patients who received IMFINZI. Thyroid disorders. IMFINZI can cause immune-mediated thyroid disorders. Thyroiditis can present with or without endocrinopathy. Hypothyroidism can follow hyperthyroidism. Initiate hormone replacement therapy for hypothyroidism or institute medical management of hyperthyroidism as clinically indicated. Thyroiditis. Immune-mediated thyroiditis occurred in 0.5%, 9 of 1,889 of patients receiving IMFINZI, including grade 3, less than 0.1%, adverse reactions. Hyperthyroidism. Immune-mediated hyperthyroidism occurred in 2.1%, 39 of 1,889 of patients receiving IMFINZI. Hypothyroidism. Immune-mediated hypothyroidism occurred in 8.3%, 156 of 1,889 of patients receiving IMFINZI, including grade 3, less than 0.1%, adverse reactions. Type 1 diabetes mellitus, which can present with diabetic ketoacidosis. Monitor patients for hyperglycemia or other signs and symptoms of diabetes. Initiate treatment with insulin as clinically indicated. Grade 3 immune-mediated type 1 diabetes mellitus occurred in less than 0.1%, 1 of 1,889 of patients receiving IMFINZI. Immune-mediated nephritis with renal dysfunction. IMFINZI can cause immune-mediated nephritis. Immune-mediated nephritis occurred in 0.5%, 10 of 1,889 of patients receiving IMFINZI, including grade 3, less than 0.1%, adverse reactions. Immune-mediated dermatology reactions. IMFINZI can cause immune-mediated rash or dermatitis. Exfoliative dermatitis, including Stevens-Johnson syndrome, SJS, drug rash with eosinophilia and systemic symptoms, DRESS, and toxic epidermal necrolysis, 10, has occurred with PD-1/L1 blocking antibodies. Topical emollients and/or topical corticosteroids may be adequate to treat mild to moderate non-exfoliative rashes. Immune-mediated rash or dermatitis occurred in 1.8%, 34 of 1,889 of patients receiving IMFINZI, including grade 3, 0.4% adverse reactions. Other immune-mediated adverse reactions. The following clinically significant immune-mediated adverse reactions occurred at an incidence of less than 1% each in patients who received IMFINZI, or were reported with the use of other PD-1, PD-L1 blocking antibodies. Cardiac vascular, myocarditis, pericarditis, vasculitis. Nervous system, meningitis, encephalitis, myelitis, and demyelination. Myasthenic syndrome, myasthenia gravis, including exacerbation. Guillain-Barré syndrome, nerve paresis, autoimmune neuropathy. Ocular, uveitis, iritis, and other ocular inflammatory toxicities can occur. Some cases can be associated with retinal detachment. Various grades of visual impairment, to include blindness, can occur. If uveitis occurs in combination with other immune-mediated adverse reactions, consider a Voigt-Koyanagi-Harada-like syndrome, as this may require treatment with systemic steroids to reduce the risk of permanent vision loss. Gastrointestinal. Pancreatitis, including increases in serum amylase and lipase levels. Gastritis, duodenitis. Musculoskeletal and connective tissue disorders. Myositis, polymyositis, rhabdomyolysis and associated sequelae, including renal failure, arthritis, polymyalgia rheumatic. Endocrine, hypoparathyroidism. Other, hematologic immune. Hemolytic anemia, aplastic anemia. Hemophagocytic lymphohistiocytosis. Systemic inflammatory response syndrome. Histiocytic necrotizing lymphadenitis, Kikuchi lymphadenitis. Sarcoidosis, immune thrombocytopenia. Solid organ transplant rejection. Other transplant, including corneal graft rejection. Infusion-related reactions. IMFINZI can cause severe or life-threatening infusion-related reactions. Monitor for signs and symptoms of infusion-related reactions. Interrupt, slow the rate of, or permanently discontinue IMFINZI based on the severity. See USPI dosing and administration for specific details. For grade 1 or 2 infusion-related reactions, consider using pre-medications with subsequent doses. Infusion-related reactions occurred in 2.2%, 42 of 1,889 of patients receiving IMFINZI, including grade 3, 0.3% adverse reactions. Complications of allogeneic HSCT after IMFINZI. Fatal and other serious complications can occur in patients who receive allogeneic hematopoietic stem cell transplantation, HSCT, before or after being treated with a PD-1/L1 blocking antibody. Transplant-related complications include hyperacute graft versus host disease, GVHD, acute GVHD, chronic GVHD, hepatic veno-occlusive disease, VOD, after reduced intensity conditioning, and steroid-requiring febrile syndrome without an identified infectious cause. These complications may occur despite intervening therapy between PD-1/L1 blockade and allogeneic HSCT. Follow patients closely for evidence of transplant-related complications and intervene promptly. Consider the benefit versus risks of treatment with a PD-1/L1 blocking antibody prior to or after an allogeneic HSCT. Embryo-fetal toxicity. Based on its mechanism of action and data from animal studies, IMFINZI can cause fetal harm when administered to a pregnant woman. Advise pregnant women of the potential risk to a fetus. In females of reproductive potential, verify pregnancy status prior to initiating IMFINZI, and advise them to use effective contraception during treatment with IMFINZI and for 3 months after the last dose of IMFINZI. Lactation. There is no information regarding the presence of IMFINZI in human milk. However, because of the potential for adverse reactions in breastfed infants from IMFINZI. Advise women not to breastfeed during treatment and for 3 months after the last dose. Adverse reactions. In patients with resectable NSCLC in the AEGEAN study, the most common adverse reactions, occurring in greater than or equal to 20% of patients, were anemia, nausea, constipation, fatigue, musculoskeletal pain, and rash. In patients with resectable NSCLC in the neoadjuvant phase of the AEGEAN study receiving IMFINZI in combination with platinum-containing chemotherapy, N equals 401, permanent discontinuation of IMFINZI due to an adverse reaction occurred in 6.7% of patients. Serious adverse reactions occurred in 21% of patients. The most frequent, greater than or equal to 1%, serious adverse reactions were pneumonia, 2.7%, anemia, 1.5%, myelosuppression, 1.5%, vomiting, 1.2%, neutropenia, 1%, and acute kidney injury, 1%. Fatal adverse reactions occurred in 2% of patients, including death due to COVID-19 pneumonia, 0.5%, sepsis, 0.5%, myocarditis, 0.2%, decreased appetite, 0.2%, hemoptysis, 0.2%, and death not otherwise specified, 0.2%. Of the 401 IMFINZI-treated patients who received neoadjuvant treatment and 398 placebo-treated patients who received neoadjuvant treatment, 1.7%, N equals 7, and 1%, N equals 4, respectively, did not receive surgery due to adverse reactions. In patients with resectable NSCLC in the adjuvant phase of the AEGEAN study, receiving IMFINZI as a single agent, N equals 265, permanent discontinuation of adjuvant IMFINZI due to an adverse reaction occurred in 8% of patients. Serious adverse reactions occurred in 13% of patients. The most frequent serious adverse reactions reported in greater than 1% of patients were pneumonia, 1.9%, pneumonitis, 1.1%, and COVID-19, 1.1%. 4 fatal adverse reactions occurred during the adjuvant phase of the study, including COVID-19 pneumonia, pneumonia aspiration, interstitial lung disease, and aortic aneurysm. The safety and effectiveness of IMFINZI has not been established in pediatric patients. Indication: IMFINZI in combination with platinum-containing chemotherapy as neoadjuvant treatment, followed by IMFINZI continued as a single agent as adjuvant treatment after surgery, is indicated for the treatment of adult patients with resectable tumors greater than or equal to 4 centimeters and/or node-positive non-small cell lung cancer, NSCLC, and no known epidermal growth factor receptor, EGFR, mutations, or anaplastic lymphoma kinase, ALK, rearrangements. Please see full prescribing information, including medication guide, for IMFINZI.